Hello, I'm Dr. Sally Brooks, Chief Medical Officer of Kindred Rehabilitation Services. This session is designed for physicians, clinical liaisons, admission teams, and leadership teams at all of our facilities and sites. The goal is to challenge managed care Medicare Advantage plans when their rationale for denying care is inappropriate. Let's keep the Medicare beneficiaries at the center of care. Now, let's begin. The managed care view of inpatient rehabilitation is the following. We need to make sure that we emphasize that a daily supervision or management is needed by the physician, and we can deliver that. An inpatient rehab stay of an orthopedic patient without comorbidities can be managed at a skilled facility or home health at a lower cost. So we need to make sure that we're only sending appropriate cases for rehab level of care to the health plan to review. Note that managed care organizations are using CMS 13 as criteria for individual patients, not understanding that it is used to classify facilities. And we can educate them about this. They know that a transfer from the hospital to an inpatient rehab setting requires medical director attestation and payer approval, and that can cause lag time, and skilled transfer can be expeditious. Unfortunately, hospital case managers come to learn this over time, and they may not even give us a referral that's appropriate because they know they can more expeditiously transfer the patient to a skilled setting. It's important that we educate the plan about the CMS 13 and 60% rule. The 60% rule is a regulation for classifying facilities as inpatient rehab facilities for purposes of Medicare payment. The rule requires that a specified percentage, currently 60%, of the patients treated by rehab hospitals and units have one or more of 13 CMS specified medical conditions. Note, the 60% rule does not establish any coverage requirement for individual beneficiaries, so they should not be using that 13 list as a checkoff. These are the only diagnoses for which rehab is appropriate. It's merely a mechanism for classifying a facility for Medicare payment purposes. In fact, the rule itself contemplates that as many as 40% of patients are IRF appropriate and may have conditions other than the CMS 13. Who's our competition? Well, it's the skilled nursing facility. They advertise that they've made investments in their rehab gyms and facilities, which many of them have, and they've increased their nursing hours to manage acuity and keep their 5-star health nursing center rating. They also state they can provide up to 3 hours of therapy a day, 5 to 7 days a week. However, we know that their nursing ratios do not mirror that of an inpatient rehab facility or even an LTAC. Nurses are not trained in rehab care typically on skilled facility units, and daily physician visits are not provided in a skilled facility. We need to point out that we have a true concentrated interdisciplinary recovery focus with a lower length of stay. If you know about the market's SNF capabilities and know individual skills, that's important information to share. We have a role in educating patients, caregivers, and clinicians at the hospital. Note that all Medicare beneficiaries, whether they have Medicare fee-for-service, Medicare Advantage, and/or a supplement plan, have a notice of non-coverage appeal rights. Hospital case managers are supposed to be giving them their appeal rights, but many times in the hustle of the day do not do so proactively. So it's our opportunity not only to educate them, but patients, their representatives, referring or attending physicians, and our medical directors of those rights. Note that the patient, their representative, and/or their physician need not obtain an appointment as representative designation. They can perform an appeals service and apply for an organization reconsideration at this level of appeal without that designation. Although our CLs can provide information, including the phone number of the health plan, to initiate an appeal, they cannot file an appeal on behalf of the patient nor become their appointed representative. Health plan standard reconsiderations are 14 days. However, filing for a fast appeal in an acute setting is advised. This means that the health plan has to turn the decision around within 72 hours, and waiting more than 72 hours might cause a potential adverse consequence of a decline in function. There are 5 levels of appeal. First, you can ask the referring or attending physician of the patient in their current setting to ask for a peer-to-peer review with the health plan medical director. Sometimes including our ARU medical director or IRF medical director can be very beneficial, but very hard to do from a time perspective. If that peer-to-peer review fails, the patient, their family, appointed representative, and/or their physician can file an appeal called a reconsideration. Reconsideration by the health plan is the first level of appeal. This means that the case is reviewed by a different medical director than the one that has performed the peer-to-peer discussion. If the plan denies during the reconsideration process, they automatically must send it for review to a Part C independent review entity. CMS contracts with this entity, and the name of that entity is Maximus. If Maximus upholds the denial, the patient can request a hearing with an administrative law judge, and if they uphold the denial, there are 2 additional levels of appeal. Next, with the Medicare Appeals Council, followed by a judicial review by a federal district court. In my experience, if you have thorough documentation, the appeals will be overturned at level 1 or 2. To learn more about Medicare Advantage appeal rights, I have provided the website here. CMS provides a mechanism to assure Medicare Advantage members get their benefits. Medicare Advantage plans must report their percent of appeals that are overturned. In other words, it's not viewed favorably if the health plan is known to deny a lot of care only to have that overturned by an independent review entity called Maximus. Note that their appeal overturn rate factors into their health plan's 5-star rating. A health plan 5-star rating covers 36 different topics in 5 different categories. 3 of the 5 categories have to do with member experience, access to care, and overall customer service. The Medicare Advantage submission approval process is outlined on the following slides. Remember that our goal is to improve the communication between our services as the acute rehabilitation care provider and the payer. We want to assure that the CMS beneficiary, our patient, and the payer's enrollee receives their benefits while meeting CMS compliance guidelines. Step 1, submission. The insurance case manager or the utilization review nurse is notified of the request for an acute inpatient rehab service. They review our pre-admission screen and other documentation that supports acute inpatient rehab. Please point out to these nurses that a pre-admission screen is approved, signed, and attested to by a qualified acute rehabilitation unit medical director, and this is a CMS regulation. In other words, the referral is not being made by a nurse only, but a physician concurs that it is a rehab appropriate patient. Step 2. At this point, the Medicare Advantage plan or ACO will review the information. They compare the clinical information on the screen against one of the guidelines provided here. Some plans use Interqual, some plans use Milliman, and others may hire an intermediary such as NaviHealth to do these reviews for them. Again, these are guidelines, and the plan is supposed to be using clinical judgment of the nurses or physicians to supplement the guidelines. In other words, the guidelines are not meant to be a checklist. This is where a rehab physician or the physician attending and the insurance physician may have a peer-to-peer review at the time the case is submitted. It's important to ask for a health plan reviewer of a like specialty. So for example, not a pediatrician. They may not understand the capabilities of acute inpatient rehab. It's important to document the steps of the Medicare Advantage plan submission. In some markets, the CLs have been attaching guidelines to demonstrate to the health plan that those guidelines match up with our screen. In either case, the date and time of the authorization request, typically the time of the fax, is documented. The insurance case manager approves the request or sends it to the insurance physician if their review deems that it does not meet their interpretation of rehab criteria. Please note, all plans are required to have a physician review prior to denying the care. A nurse cannot do a denial independently. The insurance physician reviewer then makes an organization determination of either approval or upholds the denial, which is called an adverse organization determination. This determination is commuted via fax or delivered letter to the hospital where the enrollee is being cared for. It's important to point out to the utilization management nurse at the health plan, the expectation is that the decision will be delivered to the hospital case manager or delivered in person to the patient. Delivering this decision to the patient's home is inappropriate because the patient is in acute care. At this point, the enrollee, their appointed representative, or their physician may appeal the adverse organization determination known as the denial by requesting a reconsideration known as an appeal. Again, our clinical liaison or Kindred hospital representative employee may not become an appointed representative, but can provide the health plan contact information for appeals. We should always advise patients in hospitals to request an expedited reconsideration, also known as a fast appeal. This is because delaying a decision beyond 72 hours may result in a decline in function. Note, if the physician requests an expedited reconsideration, the plan must expedite the request. Note that some Medicare Advantage plans might communicate with the enrollee to ask for a reconsideration request extension. It's important that we advise patients that many times the extension is not in their favor, and they need to understand the implications of an extension. Many times the health plan asks for this extension to provide them convenience and more time to review the case. This often happens on a Friday because their staff does not work over the weekends. In other words, I would advise the patient not extend them more time for the appeal review. And if the patient is going to extend them that courtesy, that they should be asked for a form to sign so they are fully informed about the implications. The insurer reconsideration must be sent to a third-party review if the denial is upheld. This can either be internally within their plan or to an external review organization. I find that most plans review the reconsideration request internally by a second physician reviewer. Either the plan's second reviewer or a third-party entity will overturn their denial or uphold the denial. That decision must be communicated to the beneficiary with a decision letter sent by the health plan. Again, that communication should be delivered to the patient in the hospital. If the reconsideration decision is unfavorable, at this time, the health plan must submit the case file to the CMS contractor called Maximus. Typically, the time frame for Maximus decision is within 24 hours. At this point, the patient or their appointed representative may contact Maximus to determine if they received their case, and then they will be waiting their decision. At this point, the decision is communicated to the patient via hospital employee or appointed representative. Here are tips for process success. We need to note all of our event times. When did we make the initial submission? When did we give them additional information if there was a denial and we want to appeal? Other markets have tried emailing the Medicare Advantage Director of Utilization Manager or Case Manager to let them know that the patient and or physician is filing an expedited appeal. You can ask in that email message to process this in a timely fashion and also ask them for process clarification. In other words, are they going to have an internal physician review the case, or is it going to be sent to a third-party external review organization? We find it useful to include the acute care hospital administration in these email communications. This shows the health plan that both our referral partner and ourselves as the post-acute care provider are keeping the Medicare beneficiary at the center of care and making sure that they exercise their rights. Proactively, we can ask the health plan or the ACO to engage in a quality operation meeting with us quarterly to review the submission process and seek clarification. Keep in mind that your CMO, Dr. Brooks, can assist you as needed through medical director request, your program director, or CEO. Here are some peer-to-peer review tips that you can share with referring physicians or your medical director. They should start their conversation by introducing themselves by name, providing their clinical background, and their role at the hospital or the rehab unit. It's important to ask the health plan medical director the same. What is their name, their clinical background, and their role at the plan? This is when you might identify a knowledge gap about what acute rehab units do and their outcomes. This is an excellent time to provide proactive education. You should tell them that you document every intervention, including peer review via phone call, in the patient's medical chart. Emphasizing the need for ongoing daily management of both medical and therapy needs and why the care cannot be provided in the current setting or at a lower level of care is very important. Explain the risks of not having that level of care. At this point, if the second reviewer does not approve the admission, the physician may file an appeal on behalf of the patient and/or the family can do so. Remind that medical director that you have documented the conversation in the chart with their name and role at the health plan and their adverse decision. Here are some additional tips about the type of language that sets up a red flag for health plans and how we can turn that language into green light language. I'll go through one example on this slide. When we say patient lives alone, what we really mean is that the patient was independent at home prior to this event, and there's an expectation that they can return that prior level of function to maintain independence. However, if they do not have this level of care, there is a risk for them having readmission. I had a health plan medical director tell me one time that the fact that the patient lives alone is a social issue and not a health benefit. If we had documented the language as you see in the green light column, we might have been more successful. Asking for a Medicare Advantage plan or ACO Joint Quality Operating Committee can help forge proactive collaborative relationships with plans. Typically, these meetings are held quarterly, and committee members include the host hospital or our JV partner administration, our unit or hospital medical director, program director or CEO, and CLs. From the health plan, it's advisable to have their director of utilization or case management along with their physician reviewers. I often create a draft agenda and send that with an invitation to the meeting. Here's a sample agenda. Introductions, referral rates. And when I speak of referral rates, we want to let them know our overall referral rate and what we internally deny because the patient's not appropriate. We also want to share what we refer to that and other health plans and talk about the admission conversion rate. It could be that other health plans are more lenient, and it would be important for the health plan we're meeting with to see that they are much more restrictive. We also want to be prepared to share their patient population metrics and individual patient outcomes. For example, for their old patient population that we've cared for, what is the case mix index? What was the admission FIM and the FIM gain? What were most of their patients' discharge disposition? And where patient did return to acute care, be prepared to discuss those case specifics, why that occurred. It's important to also ask the health plan or ACO their experience with our submission for these reviews, and we can provide them open and honest feedback about our experience with their review process. The goal here is to develop a process that will assure Medicare beneficiary access, but also create efficiencies. Let's now go over an acute inpatient rehabilitation case study. This is a 56-year-old male with many chronic illnesses as listed. Prior level of function was modified independent living with home health care, support, and a capable spouse. A non-Kindred LTAC stay followed a hospitalization for this patient, and he was transferred back to the hospital for acute respiratory failure requiring intubation. 2 weeks later, the patient had a trach and peg placed, and 2 days after that was transferred back to the non-Kindred LTAC for vent weaning. At the LTAC, they became tolerant of the trach color during the day with 28% FiO2, cap trach, and BiPAP at night. They were tolerating and progressive therapy at the LTAC. The request is to advance to full rehab to return home with maximum independence at the prior level of function. New comorbid conditions were this urinary retention with an infection, anemia, and malnutrition. We also noted that the labs and vital signs were stable at the time of the request. Here's additional information that was on the pre-admission screen. Patient was prior independent with ADLs and now required total assistance with eating, toileting, and prior they were modified independent with lower dressing and bathing, and now modified assistance with bathing, min assist with dressing, and transfers. You can review the rest of the case here. Our inpatient recommendations on the screen were for 24-hour nursing care, 180 minutes of therapy a day with all disciplines so the patient could regain their prior level of function, social services, and psychiatry consult, and daily physician visits to manage the following acute and chronic care needs. We state that the patient is reasonably expected to actively participate in rehab from the time of admission with an expected length of stay of 7 to 10 days. Did the health plan approve? No. Here was the rationale. The patient can continue at the LTAC level until the pulmonary status and trach is stable, then be discharged to skilled care. They're questioning whether the patient can really withstand 180 minutes of therapy a day, and they also state that skilled facilities in the market advertise they can provide almost 180 minutes of therapy a day. How do we get to yes? Recall that you are the clinician, or you are the clinician talking to the clinical liaison who has reviewed the chart thoroughly and there have been a bedside evaluation. However, the utilization management nurse and health plan medical director are reviewing notes scanned into the computer file and comparing them to Milliman guidelines. We have the advantage because rehab care clinicians can provide more detail than is provided in a guideline. In addition, you're most familiar with the IRF or acute rehab unit clinical criteria and the level of care that can be delivered in your individual setting. Keep in mind, many utilization management nurses and medical directors have never set foot in a rehab facility. This is our advantage and opportunity to educate the staff about what we can deliver. Rehab care is driven by patient-centered care, attaining the highest quality outcomes to attain maximum function in the least restrictive environment. Health plan clinicians are motivated by reducing inpatient admissions. That's a fact, and so it's unclear in this case which organization has the advantage, but I'd like to think that is Kindred Rehabilitation Services. So how would we reshape the language of our submission to the health plan? Certainly 24-hour nursing care is fine. We might also want to say that we have higher nursing ratios. Here's the review of what we submitted to the health plan. Here's how we can change that red language to green light language. Again, 24-hour nursing care, let's give them our nurse-to-patient ratio. 180 minutes of therapy a day, 5 days a week. Do we have 6 or 7 days a week? Can we be more specific about what those therapists will do? And let's make sure that we don't send a red flag. We state in our review that the prior level of function was independent ambulation with home health aid assistance for meal prep. In fact, when we look at the therapy notes, the prior level of function was modified independent with lower dressing and bathing. So we want to state that we expect the patient to get back to that prior level of function and not necessarily attain function that they did not have prior to the acute event. Social services for discharge planning. We might also state that the patient's eligible for an in-home assessment or a trial in the in-home trial unit that's on our facility. And psychiatry consult, let's not send a red flag that they have a behavioral health disturbance that will impair their ability to cooperate and benefit from therapy, but rather we're doing this to manage the anxiety related to the trach decannulation. Daily physician visits to handle and manage the acute and chronic conditions. We talk about trach collar maintenance. Would there be an opportunity to actually decannulate the trach while on the rehab unit? You can read the rest of this slide, but this is an example of how we can turn red light language into green light acceptance. Thank you for participating in this session on the crucial topic of managed care success. We want to keep the Medicare beneficiary at the center of care and make sure they are receiving the benefits they so richly deserve. Thank you and have a great day.